Thank you, Ta, and thank you everybody for attending this week's webinar. Today we're going to present about BAO systems and our COVID-19 pandemic preparedness and response efforts. So to give you a little bit of background about BAO systems, we're a leading global digital development company who has expertise, staff skilled across various areas, including public health, data science, health information systems, software engineers, and system engineers. We believe that as a result of our multidisciplinary expertise that we really understand the challenges and solutions to using data. A number of our staff have worked for NGOs globally and have expertise in monitoring and evaluation. To give you a little bit of information about our country, we currently are working with about 100 partners who have presence in over 70 countries across the globe. We are currently supporting about 400 DHIS2 instances for these partners that ranged from small scale one project systems to multilateral projects, including key support around DATM, the Global HIV/AIDS reporting system. We provide a number of services and products that can range from technical advice to DHIS2 and Dharma implementation. I'll speak a little bit about both of these platforms throughout my presentation. We also support a number of integration and interoperability solutions and custom software and app developments, analytics and insights ranging from providing support around analytics maturity assessments to implementation of our analytics platform, which I will also touch on during this presentation. We are the largest DHIS2 hosting provider based in the United States. And as I mentioned before, we're currently hosting over 400 DHIS2 instances. We have master trainers in DHIS2 and have a number of staff that have worked closely with ministries of health around the world to provide support around health information systems, health system strengthening, with emphasis on data use. So today we're going to talk a little bit more about the solutions and products that we have to optimize the COVID-19 preparedness and response efforts. Showing here is just a quick summary. This is actually information from yesterday through data available from Johns Hopkins about the number of cases worldwide of COVID-19, the number of deaths, and the number of patients that are known to have recovered from COVID-19. So first, we're going to talk a little bit about the vision of how BAO Systems envisions that we can better prepare and respond faster to the COVID-19 pandemic. During the last several weeks, we've witnessed a number of countries, including China, Italy, Spain, and the United States, how localized spread of COVID-19 in densely populated areas can easily overburden healthcare systems. In many low and middle income countries, the COVID pandemic threatens to overwhelm already strained health information systems and health systems, where the number of hospital beds per population is far less compared to Europe and the United States. For example, looking at Nigeria, there's an estimated 1/2 bed per 1,000 people. And so you can imagine how easily the health system can be overwhelmed given the quick spread of COVID-19. Furthermore, discrete populations within these countries are at increased risk of experiencing COVID-19 complications due to the high prevalence of chronic conditions such as HIV/AIDS, tuberculosis, malaria, non-communicable diseases like hypertension and diabetes, as well as widespread poverty and malnutrition rates. It's critical to mount effective preparedness and response strategies to protect these most vulnerable populations, minimize COVID and mortality globally. In this rapidly changing environment, BAO Systems is offering to support to improve data availability, accessibility, and use to inform COVID-19 response and preparedness efforts. Our approach relies on utilizing existing data to identify communities and populations at high risk for COVID-19 transmission, as well as complications from infection, in order to prepare local health systems for the surges that they can expect. As COVID-19 surveillance data are collected, these data models can be updated to track transmission spread within communities to community and used to continually inform decision making from across all levels of the healthcare system. Using these data, we envision a scenario where governments can target communities for enhanced communication about physical isolation in order to flatten the curve, to better prepare their health system for surges in COVID-19 cases, and to ensure continuation of essential services and distribution of essential medicines to those who need it. I'm going to talk a little bit about the different types of data sources that currently exist, which can be used to inform COVID-19 preparedness. We already know that population dense areas are at high risk for accelerated spread of COVID-19 without strict isolation measures. We've seen how in China, Italy, Spain, and even in the United States, how transmission has spread quickly throughout communities and populations. And we've seen how those isolation measures have been put into place. We also know that immunocompromised individuals, such as those infected with HIV, in particular HIV infected individuals who are not currently receiving ART, are at higher risk for COVID-19 complications. Looking at these data on maps, we can actually identify populations who are at higher risk for COVID-19 spread, as well as for complications. Right now, we're looking at a map of an area where we population density, and on the right-hand side, the number of people who are currently receiving ART. If you were to imagine the ability to overlay these maps together, you can see how we can develop models that would identify those populations that are at highest risk for overwhelming the healthcare system. Other data that can be used to inform this include population demographic data, including information about the elderly population, those 60 and older who we know are more susceptible to disease, those who have chronic lung conditions, using household cooking fuels as a proxy indicator, and individuals who smoke, for example. Using these data, Frame has come up with a model for a risk profile in which discrete populations can be ranked according to their risk profiles for COVID-19 disease. Frame is a company that delivers precise information about people down to the 1 square kilometer level in Africa, Asia, and Latin America. They've made available to the public neighborhood level data spanning more than 70 countries for commonly referenced demographic, lifestyle, and health factors to develop their COVID-19 risk profile. So partnerships with organizations such as Frame, or access to the data that they've made publicly available specifically for the COVID-19 response, we can envision a situation where these maps, combined with population density and healthcare statistics on HIV, AIDS, tuberculosis, malaria, and other NCD diagnoses, can be analyzed together to inform a better risk profile at the community level. And this will enable us to identify health facilities that serve these populations and are at risk for seeing an increase or a rapid increase in patient load due to COVID-19 infection. As I mentioned before, the COVID-19 surveillance data can be used together with this to continually assess and reassess community risk profiles, And as you can see here, as the number of cases increase from community to community, we can actually use that information to inform and predict where COVID-19 will spread within a country. So again, I'm showing you this slide again just to show how these data can be used together to create integrated data analysis outputs that can then inform preparedness and response actions. Again, a lot of the preparedness and that we are focusing on is really the reallocation of essential personal protection equipment, or PPEs, other hospital equipment such as ventilators, and essential medicines, both to treat COVID-19 cases, as well as to ensure that those currently on long-term medicines are able to receive their drugs despite the surge in hospitalizations and potential isolation measures that are being put in place in countries. We've seen in a number of countries how the healthcare can be easily disrupted and overwhelmed, creating a shortage in these essential equipment as well as essential medicines. And this is something that can be used to help prevent some of the measures that we've seen currently. In addition, these data, together with information such as health workforce, we can look to see how health workforce can be redistributed within a country to meet those surge demands. And as more COVID information are continually coming in on actual cases of COVID-19, how that might need to be continually reallocated and reused for decision making at the ground level. So to continue our vision, to think about the tools, systems, and processes that need to be put in place in order to achieve this scenario where we're able to use data collected on the ground for constant decision making. First, we need to be able to collect the requisite data. So in addition to using existing data to be able to collect COVID-19 surveillance data on a day-by-day basis to continually inform the analyses. We need the ability to analyze existing data and to integrate those data to create these more comprehensive data analyses. Lastly, we need to be able to display these data and share them with stakeholders across health system levels so that they can use the information and make decisions based on the information available. Throughout the rest of the presentation, we're going to focus on methods that BAO can support data collection, data integration, and data use. So first, talking about data collection, we recognize that there are a variety of primary data collection tools already being implemented on the ground, including EMR systems, ComCare, OpenSRP, DHIS2, COBO, and others. One challenge to existing tools is the ability to quickly develop and deploy new data collection forms. In areas that lack an existing data collection tool that can be quickly deployed or updated for COVID-19 surveillance, we're offering the Dharma platform as an easy, scalable system to collect COVID-19 risk assessment data, surveillance, and contact tracing information. Dharma platform was recently acquired by BAO Systems and is a robust data collection tool that enables the quick deployment with no downtime and a full data management solution for an immediate first response to a humanitarian emergency. Dharma enables people with little to no technical expertise to rapidly design, implement, and scale a complete ecosystem for data, regardless of connectivity or language. Data can be collected on or offline and is available through Android and iOS devices. The Dharma platform or we have multiple modules for implementation of the Dharma platform. And what I'm going to talk about, walk you through right now, is both the healthcare worker self-assessment and how that can also be used to create a case-based surveillance tool. So right now I'm going to walk you through Dharma. So showing here on my screen is the Dharma platform. And right now I'm going to take you through the COVID-19 self-assessment form. This self-assessment form is aligned with CDC recommendations around healthcare worker self-assessment, and it allows healthcare workers and facilities to assess their own risk for COVID-19 exposure and infection. This can also be used by healthcare workers to assess the risk and exposure history of incoming patients that may present at a health facility. And it's a solution for providing an intuitive way to immediately collect ground truth data of a population. So what I'm going to show you right now is the form builder. So this is the form in which you would actually use to create the form, where you can create form settings. You can create fields such as today's date, and you can determine or identify what type of field should be allowed. And so when you select a date, you'll see this as a pop-up where a provider or healthcare worker can easily select what that date looks like. You can also set up a number of fields such as name, date of birth, age, for example. In terms of COVID exposure, this particular form has been programmed to first ask about whether or not an individual has been exposed to COVID-19, and this is required, where you can have a yes/no field. You can collect information about the last date of exposure, again, selecting a date field. You can look at information such as a contact of known case ID, where you allow an open response. And again, this is just the form builder part. If I wanted to go and look at data and actually collect data, again, this is the web portal application that you're seeing, not the mobile form, but the mobile form looks fairly similar as well. This is what a provider would actually see in terms of the form and for enrolling a new patient. So if you wanted to select today, you can put in today's date. You can enter a person's name. You can enter the person's birth date. So for example, if I wanted to select a different date, that was the person's date of birth. You can enter the person's age, identify the gender of the individual, and continue on this form. This takes you through a structured data collection form where you can proceed from one form to the next until you complete everything. So I'm just going to quickly go through this again, just to show you how one would complete the form. So if you're a healthcare worker, this is the order in which you would collect your form. So again, if looking at the COVID-19 exposure information, have you recently been exposed? Yes. You can look at the date of last exposure. Potential exposure location, I can say Los Angeles, USA. You can select the country. And say yes, that you've been in contact with a known case. If the healthcare worker had this information, they could enter the known case ID of the index case, and that would enable linking of these two records. Now, exiting out of this Dharma platform, in addition to enabling data collection, it also enables results of these data. So shown here, and we only have a couple of cases filled out, but if I wanted to look at COVID exposure information, for example, you can see the different variables and fields across here. And you can look to see whether or not, of all the cases that were tracked and registered, how many of them were potentially exposed, the date of last exposure, if those were all entered, country of exposure. Again, we don't have a lot of cases registered in our proof of concept right now, but you would be able to see by case what that original country of exposure was. And this provides just a nice way for system users to be able to visualize their data quickly as they're coming in. You know, one of the advantages of Dharma platform is if you wanted to change anything in the form, say adding a field, for example, all you would have to do is to come here, add the field, edit the question, and it would be immediately deployed to all of the mobile devices that had the application downloaded onto it. So there's no lag time in terms of updating a field, and for healthcare providers or frontline healthcare workers to have that available on their data forms or on their mobile platform. So what are some of the advantages of the Dharma platform? Again, I've mentioned the quick downtime for this. There's no training required for end users. It can be implemented at scale, and it aligns with CDC WHO recommendations. In terms of ways that BAO systems can help, we can help you to customize the forms and deploy it, as well as integrate with DHIS2, which I will talk about briefly later on in the presentation. Now, many of you guys probably attended the session last week in which DHIS2 presented on their surveillance systems. I'm not going to go into detail about these forms other than they have a number of forms that enable case-based surveillance through their tracker module, as well as high-level surveillance through the aggregate or event data model. Um, the recordings, I believe, are available on the website, and you can find out more information about that. In terms of the DHIS package, BAU systems can help with installation of the configuration packages in a new DHIS2 instance or an existing DHIS2 instance. We can help extend the monitoring capabilities or DHIS2 functionality through additional app development or configuration. We can provide support around creating analytics and DHIS2 dashboards based on the stakeholder. We can also provide support around hosting of DHIS2. The next portion of our presentation is going to focus on allowing integration. So before, when I talked about our vision for COVID-19 preparedness and response efforts, I discussed about the ability to integrate multiple data sources, including COVID-19 surveillance information. BAU systems can provide support around leveraging existing infrastructure to improve interoperability between data systems that would enable governments and organizations supporting them to integrate COVID-19 surveillance data with pre-existing information. So shown here is just an example of how COVID-19 and HIV/AIDS data can be used together. Again, using Nigeria, an example, looking at existing HIV/AIDS information to identify populations that are at risk, as well as areas where the healthcare system needs to ensure continuous access to ART. There's a number of tools that BAO Systems offers to help with integration. One of them is our integration driver, which enables data flow from one DHIS2 instance to another. So for those countries or organizations that select DHIS2 as their COVID-19 surveillance system, we can provide support around integrating their surveillance DHIS2 instance with existing DHIS2 instances, such as the HMIS. This will enable integrated data analysis between COVID-19 surveillance information, as well as, for example, a HIV, tuberculosis, and malaria data. We can also enable integration using our integration suite of tools to connect and enable data flow, data aggregation and data flow from a case-based system to an aggregate system such as HMIS. We have current connectors that enable these data aggregation and data flow between COBO and /ODK tools. We can support this around ComCare as well as Dharma. We can also support this from a tracker DHIS2 instance into an aggregate DHIS2 instance if, for example, a government or an organization chooses to set up their COVID-19 surveillance system in a separate DHIS2 database. I showed this slide previously, but now we're going to focus a little bit more on our analytics platform and how our analytics platform can support integrated analysis. For this portion, I'm going to turn it over to Lars to talk a little bit more about our analytics platform.
All right. Can you see and hear me now?
Yep.
All right, excellent. So, thanks a lot, Karen. So we've been covering a lot on how to get data into the system, and we're now going to talk a little bit about what BEO can do in the sense of the analytics platform offering that we can provide. So at BEO now, we've been working for some time on a new offering that we call the analytics platform, and essentially this platform is all about ingesting data from different data sources. So we have what we call connectors to different types of systems like DHIS2, and also different types of databases like PostgreSQL, MySQL, Oracle, MS SQL, and so forth. We are capable of connecting to custom APIs by building sort of lightweight connectors to those APIs. And we also do support the ability to upload arbitrary CSV files, which get ingested directly into the platform. Finally, you can also connect to our public dataset catalog. So this is essentially a curated catalog of relevant public data sources that you can use to augment and improve your data and your analytics. This platform is built on the clouds, on the AWS, meaning it's quite scalable. You can have more or less any amount of data in it. It provides the ability to join data sets, meaning integrating different data sets together, which Catherine has talked quite a bit about now. And of course, you can connect to the platform with almost every BI tool out there, like Tableau and Power BI and the usual suspects. We do provide security and permissions with individual user accounts. So if you prefer to keep your data segmented and sort of have different access levels to different people, you can also do that. So at a very high level, the platform allows you to integrate different data sources. That can be things like program data, targets and results. It can be M&E data coming from, for instance, DHIS2. You can match together financial data, human resource, marketing data, and so forth into the same data platform. And that's done. You can connect with BI tools, both desktop-based as well as web-based sort of platforms and web-based portals that you might publish both publicly and internally. So with that, I'm going to give you a very quick and dirty demo of what we have. So this is the user interface for the sort of the part of the system that connects to different data sources, where the data gets piped into the platform, basically. So this is integrated within what we call the BEO Cloud Manager, which is the sort of console or control panel to all of the services that BEO systems provide, including hosting and integration with DHIS2. So as you can see here, we have ingested a few sample data sets into the platform. We have COVID-19 data that we have pulled from the Johns Hopkins APIs. We have different other types of data like PEPFAR data that we have uploaded, and we also connected to the DHIS instance that Catherine just demonstrated. So if you look closely at the demo, you can see that this was living at data.baosystems.com. So from the DHIS2 connector, we can then easily connect to that instance. So it's just about to the add data source, and then you need to enter a little bit of information like data, the name, description. You can provide information about the owner and so forth, meaning that you can provide rich metadata around your data sets in your data catalog. We have the run frequency, which is essentially telling the system how often you would like this connector to run, meaning that this can run automatically. There's no need for you to sort of wake up in the morning and do this. And then it has to provide some basic credentials like the connection information to the database and to the web API, and a few other parameters, and that's it. And from there on, this platform will automatically sync this DHIS2 installation into the platform. So to connect data, you can just click Connect Data. You can choose from the different types of connectors like DHIS2, Postgres, all these kind of things, including CSV file upload, all of this. So if I want to upload a simple arbitrary CSV file into the platform, I can click I just select my datasets so far in CSV, and then when I click ingest, it will automatically import into the platform. Yeah. Postgres, SQL, and so forth. Same process. You click add new data source, and then you add some basic metadata around your data catalog, some connection information to the database, and that's it. So once this is done, let's have a look and see how it looks in the platform. So this is the DHIS2 installation that Catherine showed you. We have the normal nice dashboards that you are hopefully by now familiar with in DHIS2. With all the beautiful visualizations and so forth. This is the data visualizer app in DHIS2. As you can see here, I'm going to zoom in. As you can see here, we built some custom dimensions, age groups. We have gender, we have prioritization, and we have the standard dimensions like data, period, and organizational unit. And then we have the data like this. Now, since I've been setting up the connector to the platform, I can now easily go over to the connection tab, and I can observe my connection information to the platform. I have a host name, I have a port, I have a database, and a username. So let's have a look at how this looks in Tableau. So this is the Tableau desktop application that some of you might be familiar with. So connecting to the platform is quite easy. You go to data, you say new data source. The platform is based on something called Redshift, which is a data warehouse offering from Amazon Web Services. So we click Redshift, we enter the hostname, database, username, password that we just saw on the screen, and then sign in, and that will connect us to the data. So from here on, everything is normal as in Tableau. We now have full access to things like DHIS2, different other types of data sets, PEPFAR data, and these types of things. So on the left side here now, we can see the dimensions. And if you look closely, you can see that we have course age, we have the PSC and new prioritization, you have the ordinates and so forth, which is dynamically equal to what we have in DHIS2. So the good thing with this one is that we can dynamically connect to these data sources. So even as new data is added to DHIS2 or more dimensions are added to DHIS2, there's no need to sort of re-download the data, like lots of data all the time. This will be automatically kept up to date without getting stale as you're having a direct connection to the platform. So from here, we can do all the wonderful, nice visualizations that Tableau can do. So we can look at data like this. We have, in this case, we have different countries, and then we're looking at confirmed cases for COVID, death, new cases, new death, new recoveries, and recovery, like this, comparing some key countries. And then we can produce these things like line charts. We're looking at the evolution of the epidemic over time, where we have countries here, and then we have the number of cases. This is confirmed cases, and so forth by country. So Germany and Italy and China and so forth. And this is death, new cases, recovered, and so forth. So this is like normal stuff in Power BI, in Tableau. Sorry. Here we comparing two countries, France and Spain, death versus new cases in an area chart like this. We have a column chart here where we combine the number of cases by day over the last time period, so forth. Then, and here we have a special chart for Italy, where we look at new cases versus death in Italy over the last few weeks. And this is live data from this morning that we ingested into the platform. Then we also have the PEPFAR data. So we have also ingested in the same system. We now have the PEPFAR data. This is what we call highlight table with a colored pivot table, where we can see outliers, high values, low values for a large amounts of data. We also have ingested data from PEPFAR data from Nigeria. So what we're looking at here is the Nigerian data down to I think the state or district level, and then we can combine in this case HCC test data, which is like number of people being tested for HIV. We have TX curve, which means people currently on treatment for ART services, and so forth. TX new, that's new people on treatment. And we can combine different districts in Nigeria and so forth. You can also combine these data sources if you want. So again, like this is a mix of connectors to systems that you might have. We're also very much working on this. So if you have other systems that you would like to integrate that you don't see here, we are very much happy to connect to those as well. We have a good developer team now, so we are able to connect to new data systems as you see fit. We have a lot of the frameworks and groundwork in place. So the main takeaway is that we can connect to most data sources and get them into a common shared data platform. So I think I'll pause there. Over.
Yes, thank you, Sir Lars and Ms. Catherine. So to all our participants, if you have questions, please feel free to type them in the chat box. Our speakers will be able to see them. So we have our first question. So any of our speakers can answer. What's the current challenges when implementing this system, since some countries already have their own surveillance and analytics tool?
Yeah, so I can try to answer that. So the idea here is that it shouldn't be a problem if you have your existing system. The analytics, at least from an analytics platform perspective, this shouldn't be a problem. We really try to integrate with different data sources. So if you have an existing surveillance system in the country, we could, of course, set up a connector to that system as well. Get it into the platform, and then overlay and integrate with other data sources as well. When it comes to data collection, I mean, if you already have a data collection system in place that's working for you, then maybe you should stick with that, right? So, but the analytics platform is something that you can put on top of existing systems. That is the main point. You can integrate different types of systems and data sources with the platform.
Thank you, Sir Lars. All right, we have another question. So how much does it cost to incorporate such system for our country, like the Philippines?
Yeah, for the analytics platform, I think depending on the data source and how many data sources we're connecting into the analytics platform, the cost can range anywhere from, I would say, $20,000 to $70,000 for the initial configuration. And then we have a monthly sort of support and hosting plan that can range anywhere from $1,000 to probably at this point $5,000 on a monthly basis. But again, it depends on the complexity of the data sources that are being integrated. In terms of the Dharma platform, I'd estimate, including configuration to annual hosting, that price range could go anywhere from $20,000 to $50,000 in a year, all costs included.
Thank you, Ms. Catherine. So our next question is the system
customizable? Is the system customizable? Yes. So both Dharma, DHIS2, and our analytics platform are customizable. In terms of When I talk about configuration and customization, that's really obviously for Dharma and DHIS2, that would be customizing the data collection forms. For the analytics platform, it's customizable in terms of the types of data sources that are being connected, as well as we are deploying a new user interface in about 2 weeks, we hope. So it will be a little bit more user friendly and for the end user. In addition to that, for our analytics platform, Lars mentioned the number of BAO curated data sets. Our catalog is increasing week by week in terms of the types of data that we're ingesting, and we certainly welcome feedback on useful information that are public can be used to look at health behaviors to identify COVID-19 risk factors.
Yeah, and just to add on top of that, so everything we have showed you is really meant to be eventually customizable and configurable and maintainable by yourself, right? So everything that we demoed will eventually, you will provide with user account, you maintain and sort of own the solution yourself after it's been sort of initially configured.
Thank you, Ms. Catherine and Sir Lars. Okay, our next question is, in terms of result and testing, since some countries still have challenges on inputting a result, whether from rapid test or PCR, what parameters that can be inputted into the system? And has this system been tested to countries that already lowered their positive patient cases? If yes, how's their response?
In terms of the analytics platform, we have not deployed it in a country yet. It's a fairly new product offering that we have. And so we are just starting to get into situations where we're able to pilot our solution and have been using it right now internally to our own organization. Regarding the HIV specific use case, some of the things that we're actually working on is developing machine learning algorithms that might be able to help countries to better prioritize and target their populations in order to use their resources more efficiently. Not sure if I fully answered that question. So any follow-on questions to that, please let me know if there are any.
Thank you, Ms. Catherine. All right, we have another one. So how do you think your data can help people when it comes to preparedness during this time, especially the cases rapidly increasing in different countries?
Yeah, so going back to sort of the vision I presented at the beginning, I think we really see the use in terms of understanding where those geographic areas are that can expect rapid cases and or complications from COVID-19. And so by combining these varied data sources, such as HIV, AIDS, tuberculosis, malaria cases, as well as population density mapping, combined with information about health supplies and commodities, that we can identify the geographic areas that are at high risk for seeing an increase in COVID-19 complications, which is what is currently overwhelming many of these healthcare systems now, to identify those facilities and to ensure that they have the requisite equipment, supplies, and medicines that they need in order to better respond to the epidemic. We can also help target IPC or interpersonal communication messaging towards these high-risk communities and ensure that the proper response from that community messaging point is directed to those areas that are at highest risk. Also using the population density information, knowing which communities will have faster spread of disease. And then as the COVID cases start to trickle in and more rapidly increase in a number of these countries that haven't quite seen the surges that we've seen in Spain, China, Italy, and some places of the United States, to also identify where those hotspots are within a country, and as COVID sort of spreads within a country from community to community, being able to track that and make sure that alerts are in place to neighboring geographic areas due to population movement.
Thank you, Ms. Catherine. Our next question is from our Executive Director in AeHIN. So the question is, how does BAO compare with DHIS2, and how will BAO work in countries already using DHIS2?
That's a good question. So BAO Systems has really good existing relationships with University of Oslo, who supports and maintains core development of DHIS2, as well as a number of HISP networks that operate around the world. In terms of DHIS2, our support is specifically around installation of the COVID-19 packages that are already available for free. I think that if there needs to be any tailoring to those configuration packages for a specific country context, we can provide support around that. With regards to hosting, if the country decides to host in the cloud, we can provide support around hosting, or we can provide any support around, technical support around their own installation and ensure that they're able to host it locally. In terms of countries that are already using DHIS2, I think one of the challenges that they're facing is whether or not to integrate the COVID-19 surveillance package within an existing DHIS2 instance, or whether or not to spin up a new instance. Lars, you can correct me if I'm wrong, but I believe that most of the countries that have already started to use the COVID-19 surveillance packages have decided to house those COVID-19 surveillance data in a separate DHIS2 instance. So if that is the case, one of the ways that BAO can support a more integrated data analysis effort is to facilitate interoperability between the surveillance, the COVID-19 specific DHIS2 instance, with their HMIS, so that they can extract data and look at, for example, HIV and tuberculosis data combined with COVID-19 data.
Yeah, that is just confirmed that is correct. Most countries we've seen have opted to go with a separate installation. I think mainly because this is kind of a very sort of time-sensitive, rapid initiative where you just want things to work quickly, and it's based on disease surveillance in epidemics, and not really so well suited with more routine, long-term programs, right? Where you want to have more longer-term programs and more governance around it. So as Catherine said, like it's also then definitely possible to aggregate up the data, for instance, from cases and events and individual data in an up to aggregate data, and then exchange that with potential national systems run by MIH or others.
Thank you, Sir Lars and Ms. Catherine. I think that's the last question. We've also reached the top of the hour, so to wrap up our session, I would like to call on our chair, Dr. Bunchai Kijasanayotin, who's also on the call. Hello, Dr. Bunchai.
Yes, thank you, Kathleen and Laura, for the very informative session about the BAO system. And we have a quite audience in this webinar, and it comes from many regions, both in Southeast Asia, and also the Africa. And we hope that your information will give our member from many countries that use the DHIS2 to consider how we gonna proceed on to that. Anyway, thank you very much for giving us the valuable knowledge and information. And if there is not any question, then I would like to, I think we can end up this webinar. Thank you.
Thank you very much. This was great. Thanks for all the good questions.
Thank you, everyone. Bye.